Okay, out of respect to all of us who joined on time, why don't we begin? Welcome to this webinar, and thank you for joining us. And also thank you everybody in the Department of Psychiatry at Mount Sinai for making this webinar series possible for all of us. Much appreciated. I am Andrew Twardon. I am a clinical psychologist and director of CITPD, Center for Intensive Treatment of Personality Disorders. And today we will talk about new developments or frontiers in personality disorders. So why don't we just make sure that I have my laser on. Okay. So I would like to begin by looking at various ways of conceptualizing or understanding personality disorders that are available at this point of time. So let's start with what's referred to as categorical models. Categorical models are probably the most known. They're DSM-based, ICD-based, and essentially they involved 10 discrete categories of different personality disorders grouped in 3 clusters, A, B, C, and they are essentially treated as separate entities. In this model, a patient would be diagnosed as having one particular personality, diagnostic category of personality disorder, possibly 2 in some cases, in most cases, 1 with some features of 1 or 2 other categories as well. So this is the categorical model, probably the most known to everybody in the field. The second group of approaches or models of personality disorders is what could be referred to as individual profile model or individual profile approach. And it is somewhat similar, but it is organized differently. This profile illustrates how it is typically done. This profile represents one person who has various degrees of different personality spectra or different personality related problems within oneself. So each of these previous categories that we just mentioned before is now moved to become a dimension within a profile. And one of the distinguishing features of this approach is that it assumes that all people, all of us, all patients and all individuals have a degree of all of the 10 categories within their personality structure. So to various degrees. So some of us may have more avoidant traits, some of us may have more borderline traits, some of us may have more antisocial traits and so on. But essentially what is important to take away from this model is that everybody has features of all possible personality related problems within one's personality or one's psyche. The third group of models are models that are referred to as dimensional models nowadays, and they pose a different question. Instead of looking at specific diagnostic categories, they try to search the dimensional models. They try to search for underlying dimensions that may explain all personality psychopathology. These models usually range from 2 to 7 dimensions. Here is just a kind of schematic illustration of how they work. This illustration sort of depicts a 3-dimensional model with 3 different dimensions, vertical, horizontal, and across. The red circle here means some sort of concept of psychological or personality related health, and everything outside of the red circle would be considered to be more and more problematic or psychopathological. So these are bipolar dimensions, so to speak. So you can have too much of a particular personality characteristic, or you can have not enough of something. So let's say borderline patient would be high on dysregulation, and a schizoid patient would be low on dysregulation, and so forth. So those are dimensional models, and this is probably where the most of current theorizing and research is placed, and we will talk about it in a moment. And the the last and fourth group of models are more recent approaches to personality disorders, which really move beyond the concept of personality alone. And those models really look at a different way of conceptualizing individuality or individual uniqueness of each person. And instead of thinking about personality traits or personality features, it looks at pathology through the lens of I states or self states or mental states, something that's a little bit more dynamic than the typical understanding of a personality trait. So you can refer to those as, or you can think of those as individuality-based rather than personality-based models, and using the state approach or states approach rather than trait approach in thinking about psychopathology. And we will talk more about this group of approaches as well. You go to the next slide. One thing to keep in mind about categorical and the profile models is that not all of those categories or dimensions within a profile have the same significance or the same role in someone's psychological structure. Even in the DSM, personality disorders are organized in clusters, A, B, and C. Another way of conceptualizing the 10 categories would be to arrange them, organize them along the severity category. This is the classic Kernberg's approach, the neurotic level of personality psychopathology, the characterological level or borderline level, and the psychotic level. And also you can organize them along the dimension of awareness or accessibility. Basically, the last one, the categorization along the awareness dimension refers to the fact that some personality disorders are, or features of personality disorders are more public, they are more easily accessible to the person himself or herself, and also are more transparent to people outside of to others in the environment, in the situation. So the first layer of this organization is public. The second layer is our personality features that are a little bit more private. Those are often referred to as our private secrets, things that we do know about ourselves, but we not necessarily want to share them with others publicly. Whereas the first one is more of our public presentation, the way we like to present ourselves to others in the public sphere, at work, at school, in the community, in the neighborhood, at a party, or the grocery store, supermarket, and so forth. So there's public space, public layer of personality organization. There's private or secrets layer of personality organization. Then you have a third layer that is those are personality features that we do have. However, we are either unaware of them or we are only peripherally or marginally aware of them, and we kind of tend to push them outside of our consciousness. You can think of them as psychological blind spots. We are non-conscious or barely conscious of them, and we typically do not conceptualize or think of ourselves as having those features. The tricky part about it is that those features are often observable and known to people who know us, people who can actually look at us and interact with us. They can see certain aspects of our personality that we ourselves are not aware of. So it is, in a sense, a kind of flip side of private secrets. Those are features that other people experience or perceive in us, but we ourselves are not aware of them. And the third one is the hidden or dormant features that usually don't manifest themselves, but usually only come out in extreme situations, when we are disinhibited by a substance, or when we are faced with some sort of catastrophic situation that triggers all of a sudden, surprisingly to us, triggers a particular presentation. Occasionally, these hidden or dormant characteristics of our personality appear in our dreams, especially those dreams that we experience as nightmares, or scary or unpleasant or surprising, strange dreams that we may experience. Using that way of sort of organizing awareness and accessibility to our internal life, we can organize the existing categories of personality disorders along the same line. So this is essentially from the outside to the inside, so to speak, or from the highly accessible, high aspects of ourselves, or those that we are more aware, to those that we are less aware. So one way of looking at this progression of awareness would be to think that these four personality spectra are typically organized in the public sphere of public presentation. This is how we are experienced by others, and this is how we feel comfortable presenting ourselves to others. The borderline in the narcissistic spectrum would be placed closer to the private or secret part of ourselves. We do not advertise these aspects of ourselves, but they often become manifest and obvious to people who know us better, particularly people with whom we are in romantic or sexual relations, because they obviously know us better, and these features tend to manifest themselves more in intimate romantic or sexual personal relationships. In terms of the blind spots or features that we typically do not want to recognize in ourselves, or we do not see in ourselves with the same level of clarity, would be the schizoid, antisocial, paranoid, schizotypal presentation of features, and they loosely correspond to the dormant features that have to do with basic dimensions of biological responses to danger or threat: freeze, fight, flee, or dissociate. Dissociate are typical of schizotypal, flee, paranoid, based on fear response, fight, typical for the antisocial presentation or related to antisocial presentation, and freeze related to the schizoid spectrum. So there are two pieces to this. The first one is accessibility and awareness within the person. The second one is progression of treatment. Essentially, for most patients, especially for those for whom treatment of the first layer seems not to work, those are treatment-resistant, avoidant-dependent, histrionic, obsessive-compulsive personalities. They are treatment-resistant because typically this is not where the problem is. This is actually an attempt to cover up the more underlying, less accessible, less available to awareness aspects of one's personality. So progression of treatment typically would follow from exploring this spectrum first, or this group of problems, then typically moves to borderline narcissistic spectrum, and then eventually, as we progress in getting to know the patient, and the patients progress in the process of self-discovery through psychotherapy, often these features are encountered and explored in treatment. So the second group of models that we looked at, the first slide, are the dimensional models. And many of them, I've selected only those that are currently researched or currently prominent in a clinical sense. And those are the DSM-5 alternative model of personality disorders, which is included at the back of DSM-5 manual, ICD-11, the proposed model from International Classification of Diseases, a new model that is emerging, hierarchical taxonomy of psychopathology. And those three are mainly focused on clinical conceptualization of dimensionality. So they typically agree that there are 5 dimensions. Some models have 4, some models have 3, some models have up to 7. But this agree on having 5 dimensions, usually with these labels attached to them: detachment, antagonist, disinhibition, negative affectivity, psychosis are the typical labels attached to the dimensions that now are believed to underlie all personality psychopathology. The 2 remaining are not clinically driven, they are mainly research-based, and one of the most promising model is by Rick DePuy and his collaborated Dr. Few, and also the NIMH model, research domain criteria. So they are mainly research-based, and they are not directly easily translatable into clinical practice as much as the first 3 are. One thing to keep in mind is that this is really the terms, the labels that you see on this slide, really become the new language of personality psychopathology. This is what researchers and cutting-edge theoreticians really now debate and argue about. which labels should we use, which dimensions we should use, and and how should we name them? What kind of labels should we use? As you can see, labels differ from model to model. So it all looks good until we begin to sort of look under the hood and try to dig a little bit deeper into the very concept of personality disorders. And this is where the new developments really begin. This is the frontier of the theorizing and the frontier of research, and also frontiers of clinical practice. This is where we need to go as clinicians when we work with more complex, more treatment-resistant group of patients. So they sort of revolve around conceptual and terminological problems with the term personality. So first of all, there's no agreement on the definition of personality, both in clinical psychology, in personality psychology, and in psychiatry. There are different approaches, different ways of conceptualizing personality, and it's clearly a very wide range of definitions and ways of thinking about personality. So we still don't know how to speak and how to think about personality in a unified way, but that's really not the most important problem. The next part that is really complicated is personality really the best way is the term personality the best term to use to describe someone's individuality or uniqueness or individual differences? And the answer is probably no. Personality is a component of individuality, but it is not the same as individuality. So there is a little bit of a weakness, conceptual weakness with the use of the term personality. The next important question that keeps arising now in literature and also in our thinking about personality disorders is, are personality disorders actually disorders of personality? So in other words, is personality the best construct to explain personality disorders? And this is where, that is a big question. Should we think about personality disorders as problems with someone's personality, or should we think about them as problems about something else or with something else? So if you step back and sort of look at the universe of features or universe of problems typically associated with personality disorders, you very quickly realize that most of the criteria used in diagnosing personality disorders are essentially referring to some sort of interpersonal or relational function. So personality disorder as a aspect, as a territory within psychopathology, are essentially problems with interpersonal and relational function. So why not call them what they are? They are really problems with interpersonal relations rather than with personality. That's one way of thinking. And then if you pursue that way of reasoning, you can call them interpersonal disorders rather than personality disorders, or you can call them relational disorders or disorders of relatedness, which I think is going to happen eventually in the next versions of the DSM or ICD, that there may be a movement away from the term personality to the term of interpersonal relationality. And for those of us who are not very comfortable with the term disorder, you can also, some people propose to use the term vulnerability. So you can then arrive at the concept of relational vulnerabilities. And this is something that actually we try to experiment with at CITPD, and patients seem to embrace and prefer this term, relational vulnerabilities, rather than the personality disorder that has this kind of stigmatizing and kind of judgmental, criticizing judgmental component to it, disorder. So relational vulnerabilities is a more acceptable term to the patient and their families. Within these new developments, I would like to take a closer look at two particular models of personality disorders, or now relational vulnerability model, the first one, and then internal interpersonal states, or I states model. So the first question that we need to ask as we move away from the traditional way of thinking of personality is to sort of deconstruct the concept of individuality. As you can see on this slide, You can think of individuality as related to someone's personality. You can think of individuality related as to someone's self. And you can think of individuality as related to the I or me, which is a little bit less understood. What is the I in this triangle here? The I is the speaking subject. Is when we say I would like to have vanilla ice cream, right? We invoke the pronoun I. It is me or I who would like to have vanilla ice cream. When we say I would like to travel to Paris, right? It makes perfect sense in the English language, at least, to invoke a concept and a pronoun I in referring to our internal experience. And we constantly do it throughout the day. If you really pay attention to how often we use the pronoun I to refer to ourselves, it is quite amazing how often it happens. You cannot say, in the English language at least, my personality would like to travel to Paris, right? Or to my personality would like to have vanilla ice cream, right? You cannot say myself would like to do it, or would like to travel, or would like to have a particular dish. So there's something unique about the pronoun I and what it designates or what it points to in our sense of our own individuality, which is different from personality and different from the sense of self. And although there are many different ways of thinking about it, this is something that you can extract from a variety of different approaches to. And essentially, you can sort of narrow it down to basic differences between these three. Personality essentially is what is referred to as the neurocognitive end of phenotype. Sounds a little bit cryptic, but essentially it's a neurocognitive structure that is often referred now in research as an end of phenotype, something that actually exists within our nervous system. It is the actual configuration, neurocognitive configuration or wiring of our nervous system, brain in particular, that sort of governs our day-to-day function. Neurocognitive end of phenotype of personality. The self, in this way of thinking, can be thought of as a representation. It is an aggregated representation of oneself that one has within one's consciousness. So it is very different than personality. Personality is the actual thing. It is a actual neuronal configuration of our nervous system. The self is a representation, and it could be an image, as in self-image. It could be a schematic, or as a self-schema that we all carry in ourselves. Could be a narrative about ourselves, a story that we have, that we tell ourselves about ourselves. And it's often related to what's called episodic memory in experimental psychology. The I or me in this way of thinking is usually considered to be what's called pre-reflective direct experience of own existence or being. Right, so it is pre-reflective in a sense that it doesn't have to be articulated in language. It could be pre-verbal. It is a distinct sense that we exist, right? A distinct sense that we are here. I am here in front of my computer. You are there in front of your computer, but we have a distinct sense that we exist in this particular space, this particular moment of time, the particular space, and it is directly accessible to our consciousness. There's no question that we are there. Right, so there is this unique and different component of individuality that is different from personality, different from self, that points to the foundation of our existence as a human being with consciousness. Introducing the concept of the idea of the utility of the pronoun I and whatever it stands for, whatever it designates, is necessary to look at the relational vulnerability models within this newer approach to personality disorders. So a relational vulnerability model essentially proposes that there are three clusters of variables. The first cluster is something that's referred to as homeostatic regulation or biophysical regulation, with a host of lower level variables embedded in it. Then the second cluster is referred to as interpersonal relatedness or intersubjectivity. Again, this is a cluster of interpersonal relational variables. And there is a third cluster involved in the formation and positionality of the I. Formation has to do with development of the sense of I, and positionality has to do with the particular perspective that one has looking at others, or particular perspective from which one interacts with others in one's life. So what are these clusters? How can we think about this? What are the lower level variables within each cluster? So let's look at homeostatic regulation first. So variables or lower level dimensions in that cluster of dimensions are listed here. They involve activation with different components of it, NVS or negative valence system, PVS, positive valence systems with all even lower level specific variables involved in regulating interpersonal and homeostatic regulation, biophysical effects of stressors and trauma on our biophysicality, and what can be called neurocognitive integration versus neurocognitive disassociation, which includes dissociation and psychoticism. The interpersonal relatedness cluster involves, most importantly, the variable of a concept of ipsocentricity, which is a fancy term for self-centeredness, agency, more familiar to most of us, autonomy, alterity, where alterity or otherness is understood as one's experience of being different than others, combined with the experience of one by others as being different than themselves. Right? So that is two perspectives involved in construction of the sense of alterity or otherness. And of course, intimacy, desire for intimacy, capacity for intimacy, and desire for care and love for others, and capacity to care and love others. And lastly, there is the formation and positionality of the I, with four specific lower level variables: insight, degree of awareness of one's I or one's own being, mode in which the experience of I is formed, spatial-temporal position. Is it formed? Is it focused on the here and now, or is it focused on something else in a kind of disassociative way? And the form, how rigid or multifaceted or flexible or transcendent the formation of the I is. This thinking allows us to map out a wide spectrum of psychopathology typically associated with personality disorders. So as you can see on this slide, you have two clusters of variables: homeostatic regulation, horizontal on the bottom, from low. It means low regulation typically means dysregulation. So homeostatic dysregulation on the left, high homeostatic regulation on the right. And here you have degree of relatedness or engagement with others, or quality of relatedness and engagement with others, high and low. On the right, you can see one of the main variables of relatedness. Within the relatedness cluster is the ipsocentricity or self-centeredness, which quantifies or conceptualizes, operationalizes degree to which one is self-absorbed or focused on oneself, self-centered, right? Low and high, and this is, as you can see, inversely related to relatedness. So low ipsocentricity corresponds to high relatedness, and high ipsocentricity corresponds to low. And as you can see, you can group or map out the 10 DSM style or ICD style personality disorders into the space along the progression of ipsocentricity, moving from relatively mild ipsocentricity to progressively, tense or pronounced and problematic interpersonal. So the takeaway from this slide is that this particular model of relational vulnerability allows us to map out in a clinically relevant way a variety of different personality disorders and also related comorbid presentations that are listed here. Finally, we have the fourth group of approaches to personality disorders, and this of approaches essentially moves away from the concept of personality and personality traits. Instead of using the term personality or the idea of personality, this group of models focuses on the concept of individuality. Individuality becomes the go-to concept in explaining individual differences, also in explaining interpersonal problems. And instead of using the traits, personality traits, which are a bit more static, this model uses the concept of states. It is somewhat related to what in psychoanalytic tradition is referred to as self-states, or in philosophizing about the nature of human mind is referred to as mental states. So this is a states model, essentially. It's more dynamic, more fluid than the trait model. And this particular way of understanding individuality looks at different markers or different components of our individuality. So the first component, obviously, is our embodiment. We live in our bodies, and our bodies are uniquely ours. So body is a powerful and robust marker of individuality. Our consciousness, our subjective experience is another powerful marker of our individuality. Our location, where we are, only one person can exist at a specific location in a specific moment of time. So location actually is another very powerful marker of individuality. It points only to one person at any given time, and it is pretty robust. And the last one is the societal person, how we are all marked by the society at large, starting with our name, first name, last name, our gender, our date of birth, our social security number, our medical records, our financial records, and so forth. Everything that is collected, that is used to tag us as members of the society or members of an interpersonal group, that points to our individuality, as Andrew Twardon as being different from everybody else. And those are the societal markers that are attached to it. Within that model of the way of conceptualizing individuality, you can then map a particular individual I states. Essentially, an I state is an internal event that also has interpersonal presence, that is that carries different contributions for the different aspects of one's individuality. So there is a component of our embodiment, there's a component of our subjective experience, location, and our societal interpersonal markers. Each unique internal state sort of floats in this space and has a different position relative to each of these corners of aspects or markers of individuality, and that can be then operationalized and quantified as a particular position in the tetrahedron or pyramid space inside of it. Without going any further into this particular way of thinking, this is a very different, as you can see, way of theorizing about personality, where personality feature that we now can think of in our more categorical or even dimensional approach now becomes an I state or pathological PI state, pathological I state that is specifically defined, specifically articulated, and then related to these four markers of one's individuality. So that's the one aspect of it, the first aspect of it. The second aspect is, which is probably even more important in clinical work, in actual treatment, is the perspective positionality of each I state. Each I state or each feature of personality pathology or relational pathology is experienced and perceived differently depending on which perspective is taken. So it is experienced different in one way, subjectively by the person himself, herself. It is perceived differently by others in the interpersonal space, and also then is understood differently in our academic, scientific, or research discourse. So everything that happens to a person internally and behaviorally has this can be conceptualized, is actually observed and experienced in three different perspectives all the time. And that often creates, obviously, an interpersonal problem. If a person feels hurt and becomes angry subjectively, the subjective experiences of being hurt by someone or by something, the interpersonal experience could be he or she is angry, very different than feeling hurt. And the academic perspective would be, obviously, the person is both hurt and angry. So there are three different ways of conceptualizing each individual I state that now we have available in this particular state. These models are essentially dimensional. They just use different dimensions and different spatial distribution of dimensions in organizing psychopathology. How all this applies to treatment. So there are many different ways how this actually translates directly into what we do with patients in our practice. Before we go to the newer ways of practicing, those just so you have a sense of what's available. Those are the current approaches to treatment of personality disorders that are typically used: the transference-focused psychotherapy, dialectical behavioral therapy, DBT, MBT, mentalization-based therapy, interpersonal therapies, and cognitive behavioral therapy. There are probably some others that are, that I'm omitting here, but those are the main ones used in the space of personality disorders. They have certain things in common. Most of them are method-centered. That means they are focusing on the particular way of working with patients, be it TFP, DBT, MBT, or so forth. And essentially applies the same type of therapy, the same type of treatment for all patients in treatment. It is mainly individual, perhaps with the exception of interpersonal therapy, but most of other approaches are mainly focusing on individual work. They're usually 1 to 2 times per week, and focuses predominantly on borderline, avoidant, obsessive compulsive, sometimes on narcissistic, in general, types of problems. The newer developments based on the models, the last models that we looked at on previous slides, propose a different way of thinking about treatment. So first of all, the new approaches focus more on specific dimensions and specific variables rather than diagnostic categories. So treatment, it is not treatment for borderline personality or narcissistic personality. It is a treatment for specific components of a personality-related problem, or interpersonal, or relational vulnerability, depending which language you want to use. So focus is on dimensions and variables rather than broader categories. Treatment is individualized or highly individualized, tailored to each patient rather than manualized. It is multidimensional rather than integrative. And I will talk a little bit more about this in the next slide or in a moment. It is person-centered rather than method-centered. So again, as in previous slide, it is not one method for patients. It is really a method is devised. A method is created or in a multidimensional way for each patient. And it is informed by perspectival awareness, the one that we talked a moment ago, the subjective, interpersonal, academic differences in understanding people's internal states, different perspectives or different types of language or different types of discourse describing internal interpersonal states. And also is informed by a slightly modified model of psychological health or ontological model of health that involves several different components, such as adaptation, actualization, and realization. If we have time, we'll cover it as well. The specific relational vulnerability models and the I state or individuality or uniqueness models focus specifically on this on these components or these clusters of variables, focus on homeostatic regulation with all the lower level variables, on interpersonal relatedness, on the formation of positionality of the eye. And also all this is based on essential of some sort of analysis, understanding, unpacking of someone's individuality or someone's individual uniqueness as a kind of in the assessment stage and then ongoingly in treatment. And the focus is mainly on progression of healthy versus disruptive psychopathological eye states rather than on personality or personality traits. So it is a little bit more dynamic, spatial temporal model looking at how sequences of internal psychopathological states develop in time and across different situations. Spatial temporal progression of psychopathological eye states. Let's look at some of special issues and unique challenges that we all face working with personality disorders. So let's look at the patients population first. In our experience, at least at CITPD, self-centeredness or ipsocentricity becomes one of the central focuses of treatment at different stages of psychotherapy or different stages of treatment. Eventually, sooner or later, all patients run into the problem with self-centeredness, essentially conceptualized here as focus, excessive focus on body, consciousness or subjective experience, societal position, and the location. Right, those are the components of individuality from one of the previous slides. Excessive focus on body, consciousness, personal, societal, interpersonal markers, and one's location. Ipsocentricity is central in what can be called ipsocentric acts or ipsocentric behaviors. And they range from relatively benign self-soothing behaviors to progressively more and more concerning self-harm or autoaggression behaviors to suicidality, autodestruction, which essentially are various forms of self-centered or ipsocentric acts when instead of reacting or interacting with the location, the actual challenge coming from the location in which the person lives, the action is directed at one's own body, right? So in that sense, these acts are ipsocentric or self-centered, that they are not directed at the external problem, they are directed in a sort of dissociative ways back at one's own body. And that's part of the problem, not the only problem, but part of the problem of the second, another challenge that is now sort of permeating our practices are patients with gender dysphoria, where essentially someone's sense of one's body is very different from someone's sense of one's personal subjective experience, very different from societal markers, and very different from how it is perceived within one's location or within one's context of life. So that is a distinct problem that we deal with our patients, and actually it kind of opens up new venues and perspectives on understanding the nature of personality disorders as related to gender identity, and that is one of the fields. We also have to deal with patients who manifest what we call extreme self-centeredness. Those are antisocial, paranoid, schizoid, schizotypal patients, for whom the presence of another human being is irrelevant, right? Or there is a prominent disregard for others, right? In various ways, obviously different from schizoid through detachment, schizotypal through dissociation or psychoticism, paranoid, antisocial, but those are essentially different ways of constructing a life that revolves around one's own self-centeredness. And obviously we have emerging issues or continual emerging issues of societal and systemic culture wars, value systems among our patients. So we have this juxtaposition of personality pathology, to use that language, and politicization of the societal discourse, which creates a very complex matrix of interactions between patients who come from a variety of different socioeconomic and political and cultural backgrounds. So navigating this aspect is definitely a big challenge for practitioners nowadays, especially if you run groups. And of course, as always, safety and risk management for central in our practice. The second group of challenges is not related to patients, but related to providers, and has to do with recruitment, training, and supervision of people who are actually interested, talented, and willing to work with personality disorders. You know, that is very selecting field. Not everybody would like to work with personality disorders, but some people are very good at this for a variety of reasons that can be sort of explored. But recruitment and training, actually preparing practitioners to work with personality disorders, and then ongoing supervision is extremely important. And there are different sets of skills for individual treatment of personality disorders and group treatment of personality disorders, the latter one being probably the most challenging aspect of our practice, running groups with heterogeneous cohort of patients representing a variety of different personality disorders or relational vulnerabilities. And of course, it leads to intense and frequent transference, counter-transference-based enactments between patients and staff, between patients themselves, and between staff themselves as well. That's why we need to have a strong structure or team, frame, container, in which all these dynamics, enactments, and difficulties and challenges that we have, that we work with, can be resolved in a sort of collaborative way, rather than leading to unresolvable enactments and bad treatment. I'm looking at my clock, and I think I'm past the 45 minutes. I would like us to have a few minutes for questions and answers. I'm going to skip 2 slides that are not that necessary for this presentation, and I'm going to go straight to questions and answers. So, first of all, thank you for participating and being here. The way it works here in this webinar is that you can click on Q&A part of your Zoom screen, and if you have any questions, you can just type it in, and I will look at it and I will answer it as they come, if there are any. So, questions, please type them into Q&A. So the first question that came is, I'm wondering about how you conceptualize the frame/container for the kind of patients you are talking about. The frame, by definition, the frame is something that sustains and supports psychotherapy, right? So when you have a scheduled appointment at 5 o'clock on Friday, that is your frame, right? That is your structure. If a patient starts calling you, at some other time, or requests visits outside of the frame, that is outside of the frame, and then can be addressed as being such. So frame is anything, any spatial temporal, so to speak, organization or way of organizing your practice. It could be a place, specific place. The treatment happens only in this particular place. Treatment doesn't happen in a hallway or outside of the building or in the street or in your own apartment. It could be particular time. It could be particular form of behavior that is expected of patients to participate in treatment, and certain other behaviors may become reasons for questioning whether this treatment is possible for the person. It could be violence, could be threats of violence, or any other set of behaviors that a particular group of practitioners or particular a person practicing psychotherapy or treatment will decide to construct, to erect around your own practice. Could be a structure, could be a group of people that you work with. So it could be a bunch of different components. Usually there's a team and a structure in which psychotherapy or treatment is allowed to unfold. I don't know if I answered your question, but for the sake of time, I'm going to stop at this. What have you seen as main indicators of borderline PD? Well, again, you have DSM, you have ICD. There's a list of criteria that you can use to think about borderline personality disorder. But the problem is that many of these criteria are shared with other categories. So some of them are not exclusive to borderline personality presentation. So if you sort of narrow it down, and if you want to extract the essence of a borderline presentation, in my mind, in our mind, it would be the emotional and behavioral dysregulation, but mainly emotional dysregulation. That means, or just dysregulation, including emotional, cognitive, and behavioral. Essentially, a dysregulated way of functioning, cognitively, emotional, lability of emotionality, intensity of emotionality, inability to function interpersonally without being captured or carried away or controlled by someone's excessive experience of own emotionality. This, in our experience, this would be the sort of the most central marker of borderline presentation: dysregulated functioning, cognitively, behaviorally, and emotionally. Cognitively means including dissociations, including brief paranoid moments, inability to function cognitively or intellectually in a particular situation. The third question that I see here is, I'm wondering how much psychoeducation you would provide your client on this framework in treatment. All of it. In other words, in our experience, in my experience working with patients, the more psychoeducation about everything that we covered today, the better for patients' treatment. We want patients to be educated. We want patients to be maximally, optimally aware of how we think about it, what are the other ways of thinking about it. And actually, I run, in our clinic, I run groups that are titled personality disorders. Personality disorders 1, personality disorders 2, and now we have personality disorders 3, or self-transformation, where we actually cover pretty much the same subject matter. But again, we don't have 45 minutes. We have 2 months, actually 4 months, once a week to cover all these issues. So it goes into much greater details. But the short answer is all of it. The more, the better. The more patients know about themselves, or about how we think about them, the better it is, in my opinion. Let me see what else we have here. Psychotherapy modality has so far proven to be the most effective for severe personality disorders. So, assuming that what you mean by severe personality would be the blind spots, the schizotypal, schizoid, paranoid, and antisocial presentation. So I think that for all of those, the right combination of group psychotherapy and individual treatment is key. And of course, psychopharmacology. I mean, there's no way you can do this work without having a medical support or psychiatric support working with personality disorder. So that's essential, that's given. But in our experience, if you were to extract one particular component, except for the most difficult interpersonal patients, group psychotherapy is the treatment of choice. And the more groups per week, the better it is for treatment. So ideally, it will be five times per week groups, the way we do it at CITPD. But for some patients are not group ready, and they have to start with individual work. So for the most complex, the most severe, interpersonally vulnerable patients, individual therapy is the point of entry, and individual therapy prepares the patient for eventually to join a group, which is the treatment of choice for personality disorders in our experience. Let me look at some other questions. This is, I guess, coming from a psychologist. What personality tests do you recommend to ascertain as many dimensions as possible in order to treat them properly? What we usually use in testing our patients, we rely heavily, of course, on ways and whims, but we really like to use MMCI4. We like to use MMPI, although this is a second choice. And then we like the projective study with the TET, and then our version of Rorschach. We use those for our personality assessment. And I think that in our experience, that this combination is optimal in terms of how much time you have and how much information you gain by using these 4 tests. My bias personally is towards MMCI and the TET. I like these 2 tests, and I think that you can glean the most clinical material about dimensionality and different vulnerabilities using these 2 tests for most patients, in my experience. This is a little bit outside of my area of competence. This is a question about medications and psychopharmacological support. I will try to do my best. I'm not a psychiatrist. Which psychiatric or psychopharmacological interventions have been more beneficial for certain and specific personality disorders? So, of course, we use mood stabilizers. We use antipsychotics for anybody who comes with a psychoticism as a vulnerability. So low dosages of antipsychotics are very helpful, and I'm not going to be able to comment on which ones and how often and what dosages, but I know that they are used often. Mood stabilizers are probably the first one to go to, and we definitely do not want to use sedatives and pretty much anything else. We pretty much stay focused on these 2 groups, antidepressants, mood stabilizers, and antipsychotics for a variety of different reasons. And I don't think I can answer it with short time with any particular level of competence. The only thing I would like to comment on this is that to the extent that attachment and affiliation, dysregulation, are at the core of personality spectrum of psychopathology, we have learned that anything that increases the levels of neuropeptides in people's bodies, oxytocin, vasopressin, and endorphins, is incredibly regulating for most of our patients, especially those who are severely borderline and within the borderline spectrum. So anything that regulates neuropeptides or endorphins is incredibly helpful in stabilizing patients. Naloxone, I believe, is the medication, and also pretty much anything that is available in psychiatry to regulate levels of neuropeptides or endorphins in human body is helpful, especially for patients who experience unbearable level of pain. Okay, it's 3 o'clock. I will look at one more question, see if I can find anything that I can actually answer. might these approaches be used to encourage treatment seeking in those who are very resistant? I think that changing the language from the language of personality disorders to the language of relational vulnerabilities is a good start. It makes it easier to engage with treatment. I think that also creating what we call a good engagement entry point. In other words, we invest heavily in engaging patients in treatment, making their landing in our program as easy and as likely to succeed as we can possibly do. So we focus a great deal of attention and effort on the first few weeks of treatment, where we try to engage patients and essentially allow for some sort of rapport and attachment to develop with the primary provider and the team and the group members. So investing in the engagement part, assessment and engagement, is probably critical, because most patients either drop out after the initial assessment session or drop out within the first month of treatment because they are not engaging. And that is something that is a big question for me. How can we optimize? How can we maximize the engagement process to reduce the number of dropouts or treatment non-adherence among our patients? Okay, I think that's all we can do today within 1 hour. So thank you very much, and thank you for your patience and participation, and have a good rest of the day.